And with tonight, I'm going to turn it over to you.
Great. Well, thank you everybody for joining us tonight. As Stephanie has mentioned, my name is Cailey Crawford, and I'm the Vice President of Programs and Policy at Ovarian Cancer Canada.
And I'm Dr. Alicia, the Scientific Advisor at Ovarian Cancer Canada. We are very pleased to share how survivors across Canada responded to the Canadian edition of the Every Woman study. What we're presenting today is an overview of many of our findings, and we will be submitting our detailed findings for publication later this month and look forward to sharing our published report with you in the future.
So just for an overview, and some of you may know this already, but the Every Woman Study Canadian edition was designed to build on findings from the World Ovarian Cancer Coalition's global study of the same name. The reason we did the study is we really wanted to understand how people from across Canada accessed and experienced care and treatment, and identify opportunities for improvement. And we were really guided by the principle that we wanted every individual with ovarian cancer, no matter where they lived in this country, to access the best possible care that they could. As many of you know, this was a comprehensive online survey. It was open for 6 weeks in the fall of 2020, and it was available in both English and French. And it had over 110 questions. So for those of you who filled it out, you know that this took a long time to complete. It took about an hour to complete. And what's important to understand is that there are limitations to keep in mind as we go through these results. First is that all responses are based on retrospective recall from an individual's perspective. And so what that means is everyone filling out the survey is really going from their memory of their experience. We're not able to take data, let's say, from their health records. So there is potential for recall bias. There was also no control group, meaning that we didn't get to ask questions of women without a diagnosis of ovarian cancer. So this is especially relevant for questions regarding symptoms that were experienced prior to diagnosis. We know that there are women without ovarian cancer who may experience bloating on a regular basis. They may have had some of those symptoms themselves. So we couldn't really compare the respondents to a control group. There was no collection of outcome data, so we can't connect your responses to overall survival data. And of course, only women who are still alive were able to complete the survey. So it's just important just to keep those limitations in mind as we go through the findings. Now, as you can see here, we asked about many different topics related to the ovarian cancer journey, including participant characteristics and disease information of those filling out the survey, questions relating to understanding the pathway to diagnosis. We looked at post-diagnostic clinical care and also the impact of ovarian cancer and patient priorities. And our study, and as I say, our study explored many of the same topics as that global study back in 2018. And most of our questions were taken from that study. But because we were focusing only on one country, we had a lot more flexibility than they did, and we were able to ask for Canadian-specific information. So this includes asking for the first 3 digits of respondents' postal codes, and that allowed us to assess whether there were any regional variations in responses. We were able to adjust some of those financial questions to better reflect Canada's universal healthcare system. And because we were only dealing with 2 languages, we were really lucky that we could ask a lot of open-ended questions, which we'll touch on here tonight. Now, in terms of who filled out the survey, and a lot of you have seen this map before, so we received over 550 responses from women in 10 provinces and 1 territory. This was in both English and French respondents, and the vast majority were from urban settings. Now, in terms of the respondents, we learned a few things. We learned that the median age at diagnosis was 54 for those filling out the survey, although the ages ranged from 11 to 80. 61% of respondents had been diagnosed within the last 5 years. We were really pleased with the variety of ovarian cancer types represented. I mean, as expected, the most common type was high-grade serous, but we also had many with low-grade serous, endometrioid, clear cell, and non-epithelial ovarian cancer fill out the survey, as you can see there. Most of the respondents were diagnosed at a later stage, at stage 3 or 4. 41% had either experienced a recurrence or the cancer had never gone away, and 34% were in active treatment at the time of filling out the survey. In terms of self-reported demographic information, it showed that the majority of respondents were Caucasian. They had English or French as first language, post-secondary educated, married, and in households with a fairly high family outcome. So we would have liked to have seen more diversity in terms of the demographics. And it's also just too important to remember in that context that there's many people experiences that aren't captured in this survey. And we also saw that 23% had some kind of ovarian cancer history, either with or without breast cancer. Now, we also looked and asked a lot of questions around genetic testing, and of the 75% of respondents who had genetic testing, 19% reported having a mutation in BRCA1 or 2. An additional 8% had a mutation in another ovarian cancer risk gene, and 68% did not have a pathogenic mutation in any of the genes tested. So this includes the 56% who tested negative and the 12% who had inconclusive results. And not surprisingly, mutations in BRCA1 and 2 were increased in those women with high-grade serous ovarian cancer, whereas mutations in the other ovarian cancer risk genes were increased in other types of ovarian cancer. So in terms of some of the key messages that you'll see throughout this presentation, the survey revealed that it revealed a lot of information. One, what drives women to consult a healthcare provider about their symptoms, what impacts how long it takes to get to an ovarian cancer diagnosis once medical attention is sought, regional variations in genetic testing, treatments, and clinical trial participation, the substantial physical, emotional, practical, and financial impact of an ovarian cancer diagnosis, gaps in information provided to women throughout their cancer journey, and ultimately a need to engage a more diverse population of people living with ovarian cancer, as I mentioned earlier. And ultimately, you know, what these learnings are really going to inform Ovarian Cancer Canada's priority for national and regional advocacy going forward, and also help us. We've learned so many interesting things about the gaps in information that people experience. So really looking at the development of key resources to better support those who are facing an ovarian cancer diagnosis. So that was just a really high-level overview, but I'm going to pass this over now to Alicia, who will take us through some of the results.
Thanks, Cailey. So first, I'll summarize the complex and varied pathway to diagnosis. So before I do that, I want to show a snapshot of the information we collected on symptoms. So as you can see here, the vast majority of respondents experienced at least one ovarian cancer symptom prior to diagnosis. The symptoms experienced most often were persistent bloating and abdominal pain. However, the other symptoms, including fatigue, urinary symptoms, changes in bowel habits, difficulty eating, unexplained weight loss or gain, and menstrual irregularities were each experienced by 23 to 45% of respondents. Experience of a specific symptom varied by a few things, including stage, ovarian cancer type, and age at diagnosis. So we also asked you to select your most concerning symptom, and respondents most often cited abdominal pain at 28%. Most concerning symptom varied by stage and ovarian cancer type, but not age at diagnosis. So we were able to tease out 3 different types of awareness to determine whether any of them impacted how quickly respondents went to their doctor after experiencing symptoms. The first is general ovarian cancer awareness. So as you can see, 35% of respondents knew something about ovarian cancer prior to diagnosis, while an additional 50% had heard of it but didn't know anything about it. General awareness was lowest among respondents from Quebec and Nova Scotia. So 45% of respondents had prior knowledge of at least one ovarian cancer symptom, and this is what we're calling general symptom awareness, with persistent bloating and abdominal pain being the most commonly known symptoms. So general symptom awareness was lowest among Quebec respondents. And finally, 40% of respondents had some level of specific symptom awareness, which we're defining as prior knowledge of at least one specific ovarian cancer symptom that they themselves experienced. Okay, so now to summarize the full pathway from symptoms to diagnosis. So as mentioned, the majority, or 87% of respondents, experienced at least one symptom prior to diagnosis, with abdominal pain and persistent bloating being the most concerning. 86% of symptomatic women consulted a healthcare professional, typically within 3 months of experiencing symptoms. So family doctor was the most common healthcare provider, with ER or urgent care being the second most common. 76% of those first healthcare providers ordered one or more tests to investigate symptoms, most commonly abdominal or vaginal ultrasound. 87% of respondents ended up consulting additional healthcare providers beyond that first visit, and 90% of the time, more tests were ordered. So respondents were eventually referred to a gynecologic oncologist, with time to diagnosis from the first visit with a healthcare provider being less than 3 months in 65% of respondents. So, as you can see, and cannot read, respondents were able to provide in their own voices some of the context for their experience in that diagnostic pathway. So these personal accounts really help bring the data to life and enrich our understanding of the patient experience, including both positive and negative aspects. So importantly, we've been able to cross-reference open-ended responses with quantitative questions on the diagnostic pathway, and I want to highlight a few common themes. So first, to quote, "Doctors should know more about this cancer and do the proper tests. My cancer was seen by MRI in the emergency room when I was almost in agony because I was in so much pain." This respondent had a family history of ovarian cancer and was very concerned about her symptoms. However, diagnosis took greater than 2 years. Another example, "My doctor knew that my sister passed away from ovarian cancer, so I wish she would have taken me more seriously. Despite a family history, this respondent took greater than 1 year to be diagnosed with a stage 4 cancer with a BRCA1 mutation discovered after diagnosis. This unfortunately represents a missed opportunity for prevention of ovarian cancer." So this is a very simplified summary of the pathway from experience of symptoms to consulting a healthcare provider to ultimately diagnosis. So as you know, we currently recommend any woman experiencing symptoms for 3 weeks or more to go to their family doctor, who should then order specific tests, including CA-125, pelvic exam, and transvaginal ultrasound, and refer to a gynae oncologist if appropriate. So firstly, we were able to tease out a few subgroups based on time to diagnosis from the first appointment with a healthcare provider. So as you can see here, 37% of respondents took greater than 3 months. 30% were diagnosed within 1 to 3 months. We are considering this a timely diagnosis or good short. And this means that it's a scenario where a healthcare provider orders tests right away to investigate symptoms, with the patient diagnosed in a timely manner to allow initiation of treatment. Unfortunately, 33% of respondents were diagnosed in less than 1 month. However, despite this being short, we are considering this an acute diagnosis, or for lack of a better word, a bad short. An example of this would be women who presented to the ER with significant symptoms, followed by rapid diagnosis of poor prognosis disease. So, what predicts urgency from the perspective of both the patient and the healthcare provider? And really, what predicts a bad short versus a good short time to diagnosis? So, firstly, symptomatic women who consulted a healthcare provider were more likely to be concerned about their symptoms, were slightly younger and had a higher level of education than those who did not seek medical attention. So as you can see here, the most concerning symptom was abdominal pain in 31% of those who consulted. 71% were very or fairly concerned about their symptoms. 76% were college, university, or postgraduate educated. And the average age was 52 versus 56. So importantly, there were factors that were not different between those who consulted versus those who did not consult a healthcare provider about their symptoms, some of which are very surprising. These included having a family history of ovarian cancer or symptom awareness, both general or specific, language, ethnicity, income, or urban versus rural location. So among those who did consult, women who were most concerned about abdominal pain or persistent bloating, or who were older than 50, were more likely to seek help within 3 months. So to explain these numbers here in the brackets, women who were most concerned about abdominal pain were 3.7 times more likely to consult a healthcare provider within 3 months of experiencing symptoms compared to the reference, which in this case was women who were most concerned about menstrual irregularities. In addition, those over the age of 50 were twice as likely to go to their doctor within 3 months compared to those who are up to 50 years of age. So predictors of a timely diagnosis within 3 months of the first visit with a healthcare provider included most concerning symptom being persistent bloating or abdominal pain. And you can see here that those with persistent bloating were 9.2 times more likely to have a timely diagnosis. Healthcare provider ordering tests right away, age greater than 50, and eventual diagnosis of high-grade serous carcinoma. And all of these numbers that I'm showing you are statistically significant. So what about predictors of an acute diagnosis in less than 1 month? So predictors of this were region, specifically Quebec, where respondents were 2.9 times more likely to be diagnosed in less than 1 month. First healthcare provider being ER or urgent care, and stage 3 or 4. Note, we did not collect information on substage, so we cannot further dive into this. So what did we learn from the pathway to diagnosis? We learned that respondents from Quebec were more likely to experience an acute diagnosis. We also learned that a general or specific awareness about ovarian cancer symptoms did not impact whether an individual consulted a healthcare provider about their symptoms or how quickly they consulted a healthcare provider among those who sought medical attention. When the most concerning symptom experienced was persistent bloating or abdominal pain, there was an urgency to act from both the patient and physician perspective.
Alicia, sorry to
yes.
interrupt. I just wanted to jump in here just because I think the results around symptom awareness are a bit surprising, like we mentioned earlier, and they might benefit from some repeating. So I just wanted to really clarify what it was that we saw in that data. And what it showed us was that there was actually no statistically significant difference between people who had a general awareness about ovarian cancer or its symptoms and those who didn't, when it came to whether someone with symptoms sought medical attention or how quickly they sought out medical attention. And this was also the case when you drilled down to look at people who had awareness of the specific symptom or symptoms that they themselves were experiencing were linked to ovarian cancer. So these folks who knew that the symptom or symptoms they were experiencing were linked to ovarian cancer did not seek out medical attention when they had that symptom or go to a healthcare provider any more quickly than those who did not know their symptoms were linked to ovarian cancer. So awareness of the disease or its symptoms didn't correlate with whether someone went to a healthcare professional or whether someone went more quickly to a healthcare professional. But what did impact a person going to a doctor more quickly was when the symptom they described as most concerning was either persistent bloating or abdominal pain. It didn't matter if they knew these symptoms were related to ovarian cancer or not. What mattered was that they described bloating or abdominal pain as their most concerning symptom. So in terms of what got women to a doctor faster was not that they were aware their symptom was associated with ovarian cancer. It was that they experienced bloating or abdominal pain and described it as their most concerning symptom. And it was these two symptoms that were also correlated with a doctor ordering the appropriate tests right away. So I just wanted to tease that out just a little bit because it was a bit nuanced in there.
Thank you, Cailey. So given that, can we work to elevate concern for the other symptoms of ovarian cancer among healthcare providers to contribute to a more timely diagnosis? And ultimately, could this potentially lead to a shift from, for instance, stage 3C to 3A at diagnosis? And is this a goal worth pursuing? And this is something that we are currently thinking very hard about. Okay, so now on to key lessons and surprises following diagnosis. So before discussing what we learned, we must first emphasize the important role of genetic testing for both those individuals diagnosed with ovarian cancer and their family members. So firstly, testing for BRCA1 and 2 and other ovarian cancer risk genes can provide the opportunity for more treatment options, for instance, PARP inhibitors, if a mutation is found in a cancer patient's tumor or blood sample. If a mutation is inherited, it can also provide the opportunity to prevent other cancers associated with this gene. For instance, women found to have a mutation in BRCA1 would be enrolled in a high-risk breast cancer screening program. Secondly, discovery of an inherited mutation in a cancer patient provides the opportunity for their relatives to pursue genetic testing and prevent ovarian cancer from occurring in the first place. So now that I set the stage, as expected, predictors of genetic testing being offered included high-grade serous cancer diagnosis, which was 8.2 times more likely to have genetic testing offered. Stage 3 or 4, having a family history of ovarian cancer, and a more recent year of diagnosis, with 2016 to 20 being 2.6 times more likely than the previous 5 years. Unexpected predictors included age greater than 50. So women older than 50 were 1.7 times more likely to be offered genetic testing than those who were 50 or younger, and also region. So the likelihood of testing was the highest in BC, 2.7 times more likely, and lowest among respondents in Saskatchewan. So you can see here, these are the proportion of respondents who were offered genetic testing either before or after diagnosis. And 22% of respondents were not offered genetic testing. But most interestingly, only 2% did not wish to be tested. So there's a large appetite to be tested among those with ovarian cancer. So in terms of treatment, almost 20% of respondents had been treated with a PARP inhibitor, And this was the most common other treatment received other than surgery, which 92% of respondents had received, and chemotherapy, which was 86%. 45% of respondents overall received at least one of the treatments shown here. And in this list includes PARP inhibitors, radiation therapy, anti-angiogenics, such as bevacizumab, aromatase inhibitors, anti-estrogens, and immune therapy. So interestingly and surprisingly, use of some treatments, such as anti-estrogens and immune therapy, was decreased in those who had to travel greater than 30 minutes for their initial surgery. Other factors influencing use of other treatments included, that were not a surprise, were age, type, stage, and mutation status. So moving on to clinical trials, only 26% of respondents were offered a clinical trial and 18% participated. So not unexpected, high-grade serous cancer, stage 3 and 4, and mutations in BRCA1, BRCA2, or other ovarian cancer genes impacted clinical trial participation. However, unexpectedly, region and distance traveled for surgery were also predictors. This really emphasizes the role of these factors in several aspects of post-diagnostic clinical care. For instance, respondents that had to travel greater than 1 hour to their initial surgery were 40% less likely to be offered a clinical trial. So this 0.6 times equates to 40% decrease. And those in Quebec were 2.9 times more likely to be offered a clinical trial among those who participated in the survey. So we also asked what might prevent respondents from participating in a clinical trial in the future. And I've highlighted the top 4 answers here. So the top 4 answers were concern about safety of drugs in the trial, potential side effects, worried I'll get placebo or not adequate treatment, and cost. So we also asked many questions to understand the impact of ovarian cancer and support and information needs. So due to time limitations, we won't go into detail with these results, but Cailey will now take you through some quick highlights.
Yeah, so we just wanted to highlight when it looks at when we look at the worst long-term side effects of ovarian cancer treatment, we had fatigue, regardless of age, was considered the worst. While other side effects did differ by age at diagnosis. So for instance, anxiety, loss of interest in sex, menopausal symptoms, and depression were more often considered the worst symptoms by women diagnosed at age 50 or younger. And in contrast, neuropathy was more often considered the worst long-term effect in women diagnosed after age 50. And what's interesting is when we presented these these results to many clinicians who participated in our clinical focus groups earlier this year, and this kind of surprised a few of them, quite a few of them. And one thing that they were surprised by was they were surprised that fatigue was considered one of the worst long-term side effects by so many people. And they were surprised that hair loss hadn't been ranked higher. And we thought it was just really interesting what they sort of had expected would be the long-term side effects that caused the most difficulty for their patients and what you have told us through this survey. So I think this really helps to emphasize the importance of hearing directly from women and others to help inform Ovarian Cancer Canada about what supports are needed, but also for clinicians to hear what are the physical symptoms that are mattering most and concerning, that are most concerning to patients. In terms of emotional impact, respondents commonly considered a fear of recurrence and a fear of dying as having the worst impact, and this was regardless of age. Coping with treatment-induced menopause and loss of fertility were more often cited by those diagnosed up to age 50, while fear that the treatment will not work was more often cited by women diagnosed over the age of 50. And only 9% of respondents didn't feel the need for emotional support, regardless of recurrence status. I wanted to just read out some of these quotes. These came through the open-ended questions, and I thought they were, we thought that they really demonstrated just what the impact of some of the most commonly, emotional impacts were. So the fear of recurrence, we heard from one person, it can be very hard to mentally process the prospect of no known cure. Therefore, the constant fear of recurrence. As the years pass, family and friends forget that you live with this shadow on your life. I'm very fortunate so far, having survived 13 years, but the fear is always there. This is someone who's stage 3, high-grade serous, and currently no evidence of disease. Another woman said, the amount of anxiety that is experienced every time you have a scan and waiting for the results is the absolute worst part. I think sometimes the clinicians don't appreciate how difficult that can be. Shared by someone at stage 1, high-grade serous, and currently in treatment. And particularly unique to younger patients, this quote really stood out to us. When you're diagnosed as a young person under 40, it's even more isolating because usually none of your friends have been through anything like cancer. It's a completely different experience when you get cancer at a young age. So someone diagnosed at age 33 with stage 3 low-grade serous. And another, young people with ovarian cancer have to weigh the risks and benefits of delaying treatment for fertility preservation, or may not be given the option for fertility preservation at all. Loss of fertility is a major component to our identities, contributing to isolation, feelings of inadequacy, isolation from peers, difficulty with dating, and building families. Diagnosed at age 26 with stage 3 low-grade serous. So I think that just these open-ended questions and the quotes that you provided, I just think they bring the data to life. They give it heart, and it really allows us as an organization to see, just to kind of really see the depth of the data, and helps to sort of inform us on what supports potentially we could be helping with and what resources we might be able to provide. Looking at the impact of ovarian cancer on daily life, many women cited a practical impact of their diagnosis, with need for help with daily chores and transportation being the most common, regardless of age, and needing help with finances, personal care, and caring for dependents was more common in women diagnosed up to age 50. We also learned of the greatest information needs, which will guide us in the development of key resources to help fill the gaps. So respondents most commonly needed information on symptoms of recurrence, treatments, and coping with long-term side effects at some point since diagnosis. And the largest gaps in information, when you look at what was needed versus what was actually provided by healthcare providers, and this included information on sources of support, living with ovarian cancer, genetic testing, and information on specific treatments received. And finally, we asked participants to indicate which 3 priorities they consider the most important for improving outcomes of those with or at risk of ovarian cancer in Canada. So you can see the top priority, not surprisingly, was finding an effective ovarian cancer screening tool. Next was raising awareness of the symptoms of ovarian cancer. And third was prevention of ovarian cancer. But you can see here there are many other priorities that are also very important to look at as well. So that brings us to the end of the data sharing. Just to share some of our next steps, we'll continue to share these findings with you as we find out different ways. There was a lot of data that we went through today, and I think we could spend time on almost any section of this and really try to communicate back to you what you shared. But we also want to keep sharing findings with primary care physicians, gynecologic and medical oncologists, and others involved in cancer care in Canada, to hear their responses to the data, but also to find ways to partner, get their attention, so we can identify opportunities for improvement, including the diagnostic pathway and how those with ovarian cancer can access and experience treatment and care. We also want to work with regional stakeholders because we saw those regional variations that existed across different areas of the survey results. And we want to make sure that we're communicating those back to the provinces that are relevant in those regional variations and talk about how we can work together to address them. We're going to be developing and refining our advocacy priorities. You can obviously see how that's come through some of the data already, where we probably need to get involved and advocate. And how can we also best respond to gaps in information and support resources? Just so you know, we're submitting a manuscript to the, I should say Alicia is submitting a manuscript to the International Journal of Gynecological Cancer. This is to make sure that your voices can be heard and built upon on an international level, and with all of those who read that journal. And this is the same journal that the Global Every Woman Study published its results in. So we just felt that was a great fit. And we'll keep you updated and informed on our progress. This is really the first step is reporting back to you on what it was you said. We had a statistician, we hired a statistician to really do a deep dive. This was, just to make sure all the correlations were completed, to make sure we could identify the statistically significant results. And we will just continue to keep you updated and informed on what comes from this work. So before we move on to questions, I just wanted to say some thank yous. First and foremost, everyone who took the time to fill out that survey. It was a very lengthy survey. It took a lot of, I know, care and attention in filling it out. So we do appreciate every one of you who filled it out. We want to thank, there were women living with ovarian cancer who provided feedback on our initial questions, and they gave us feedback. We then changed some of the questions and really tried to improve the survey. So thank you to them. Members of the staff, of our staff, who've been instrumental in bringing this work to life. The clinicians, and you see some of them listed here, you may recognize them, and members of the World Ovarian Cancer Coalition Executive who participated in our focus groups and provided reactions to our initial data and asked some really great questions that helped move this forward. And a really big thank you to Frances Reed, who is the Global Every Woman Study Project Manager, who back in the summer of 2020 spent a lot of time with us helping us adapt the global survey to the Canadian context. And I just want to finally say thank you to everyone who took the time to listen this evening. It's been a real pleasure working on this project, and it's really had such an impact on everyone at Ovarian Cancer Canada. We're delighted to be able to share the results back to you. So with that, I will pass this back to Stephanie, and I think we're happy to answer any questions you might have.
Thank you, Cailey and Alicia. That was an excellent presentation. We do have a couple of questions, and I do see that on your thank you slide. I know that there are a few women that you've listed on there that are with us tonight. I see them in the participants. So I'd be very interested if you have filled out the survey, if you have thoughts that you'd like to share with us tonight on any of the results that they've shared, just pop those in the Q&A and we'll make sure to get to them. So we have one attendee who is curious to hear what your initial thoughts are on regional variations and why they happen. Tough question. I'm from a province where some of the results were lower than we would have liked. So I would be interested in hearing this as well.
Yeah, I mean, I think that, well, it's interesting when we presented some of the initial data, let's just look at what we called the bad short, the acute diagnosis. And we saw that in Quebec, at first we thought it was great news because we said, wow, like women in Quebec are getting diagnosed so quickly. But then as we dug deeper, we were like, wait a second, there's so many being diagnosed through the ER, et cetera. We did raise this. There was a gynae oncologist we presented, Walter Gottlieb, who's on our thank you slide there, we presented to him the results, and he sort of said, you know what, this isn't surprising. So it was interesting to reflect some of those regional variations back to some folks from those provinces that weren't very surprised. But this will be part of our advocacy. Why is it that in Quebec, more women are having to go to the ER to get to a diagnosis? And this is exactly the kind of data we need to be able to spur on those discussions. I think for Saskatchewan, and Steph, you know this better than anyone. Yeah. I think we get some of the reasons why there have been, I think, the regional variation in Saskatchewan, was there an impact
Genetic
on clinical
testing.
trial too? Genetic testing, but was there clinical
Genetic
trial?
testing and clinical trials, yeah.
And I think that's what's so exciting about Saskatchewan making the $1 million research investment, is that I think they knew that there are aspects they really need to work on there. And in fact, we're really excited that through some of their research projects that they're investing in, it will be helping with the genetic testing piece and the clinical trial piece as well. Alicia, did you?
Yeah. So I'll just kind of build on what you're saying. So when we were presenting to Saskatchewan people on the ground, they were not surprised either in terms of clinical trial participation in genetic testing. And clearly it was a reflection of, having a lack of gyne-oncs there for a period of time. But the $1 million provincial investment, the bulk of the money is actually going towards setting up a, internal in Saskatchewan tumor testing and drug prediction program, which will take things to the next level in terms of genetic testing and providing the opportunity for patients in Saskatchewan to have access to things like PARP inhibitors.
I think too, and I look, because I'm really wanting to answer the question, which is why do you think these differences exist? And I think, looking at British Columbia and the fact that they had their genetic testing was in a positive way increased. And so I think, again, presenting back some of this to the provinces to say, why do you think this is happening? I think a lot of folks know some of those systemic barriers that are in place or the challenges they face. And all of this is a way to open up the conversation to how we can advocate for change effectively and like really getting to the heart of what might be going on. And I think to our clinical audit, the State of the Nation clinical audit will also help to kind of tease out because that's really focused on regional variations, is why are things working particularly well in one province and not in another?
And this might be premature, but when do you think some of those conversations may start to happen with the provinces?
Well, I think they'll be starting fairly soon. I mean, part of our goal for this quarter is to share the results, just like we're sharing back with the community today. We will, and just like we shared back with focus groups previously, we're really trying to get in front of are the family physicians. Really want to talk to the Canadian Partnership Against Cancer about how they reached family physicians, talk about some of this on a higher level with them. And I think too, we'll be seeking out opportunities to speak across the provinces that did see the regional variation, those that didn't, really trying to get that feedback about and getting those conversations started.
That's awesome. It's exciting. It's exciting to hear these results. I do have a couple of questions and a comment. So I just wanted to say that we do have one comment I'm going to read. I just wanted to comment on Cailey's statement around the surprise of healthcare physicians when they learned about the factors women struggled with following treatment. For me, these reinforce the importance of patient partners teaching medicine and research what is the most important for us. Only patients can provide these priorities. And you're so right. And that leads right into another question that I have on here is how do we find out about surveys that we can participate in or other research opportunities that we may be able to participate in?
So I'll take the research opportunities one. So obviously for surveys, anytime there's a survey that is open to participation, we would be sharing it through our multiple channels for OCC. But in terms of research, the best way to get involved is to join the Patient Partners in Research program. This was initially created as part of OVCAN, but I think it's growing and I don't see any reason why it would not expand to other areas of research that we're doing. And Donna Pepin is actually co-lead of the Patient Partners in Research. So this is a team of right now 25 women from across Canada, all of whom, except for one, is personally affected by ovarian cancer. And we meet monthly for education opportunities. And also as any research opportunities arise, usually within OVCAN, but also others, we kind of present the opportunity to the whole group and look who's interested. And make those connections as they arise. So Patient Partners in Research.
Yeah, thanks, Alicia. I just want to jump in, Cailey, before we
Yep.
threw it back to you. I do see in the participation list that there's quite a few joining us tonight that are involved in that.
Yeah, and in terms of surveys, I mean, we do hope to do the Every Woman study again, so not every year, but obviously we want to track to see, are we seeing differences? Are we seeing improvements through our advocacy? Hopefully we will, as we can also drill down onto year of diagnosis. Maybe some folks diagnosed more recently will be, will show differing results, and we'll be able to do some comparisons. So I think that's great. I think in Quebec, we are partnering with an organization in Quebec around patient-reported outcomes, and really trying to do focus groups with patients in that particular province to, in partnership with an organization there, to get, again, those patient-reported outcomes and patient values. And ultimately, we're always looking for people to share their story. I think as we move forward and have when we have specific advocacy pieces, whether it's along the journey, the pathway to diagnosis, let's say, or, experiences with clinical trial participation, not being offered a clinical trial, we'll be looking for stories that really, again, those open-ended questions were such a gift, because they really do bring that to life. And I think really drive home, when you're dealing with a decision maker, it's the stories that get their heart. The data is fine, and any people have heard me say this before, facts fade, but stories stick. And I think that definitely getting involved with Ovarian Cancer Canada, you guys are connected to us already. Obviously, you're listening here tonight, but I think there's always ways to share your story as we advocate and share these results.
I also want to add in too, so when we repeat the survey, there's definitely some aspects that we learned through the questions and responses that we should have included. So we'll be, continually improving and adding different elements based on the responses we received. For instance, one theme is making sure that we can capture the unique experience and treatments of those diagnosed with less common types of ovarian cancer, or at a younger age. So our median age was 54. And we had a very small proportion, I think around 12 or 13% that were less than 40 at diagnosis. So it'd be great to, expand in different areas like that.
That leads into a little bit of our next question here is there an increase in the number of younger women being diagnosed with ovarian cancer, women under the age of 40?
I don't actually know that statistic, to be honest. That is a great question. I will need to dig into that, because I actually don't know the answer. Yeah.
And if Alicia
Linda,
doesn't know,
I've got your name here, Linda. I've got your name here, Linda. So I will follow up with you on that, Linda.
Please do that.
We do have a couple more questions here. So this is from Viviana. Thank you for sharing the results of the study. Did you consider, or are you considering, studying results of new treatments such as PARP inhibitors to improve survival rates, and or studying side effects and overall outcomes of new treatments? Are there any research projects to evaluate these results? So that's a loaded question. You got a few in one there.
Well, I mean, they're great questions. I think we can't tie our data when we're doing a survey like this to outcomes. So I think that would be one thing, unfortunately, like we can't really make those connections. And in terms of impacts of side effects on treatments, I mean, my gut reaction, Alicia's got her hand up, but I'm going to try for it. But I mean, my gut reaction is to say, I think a lot of the clinical trials that are evaluating these treatments are looking at side effects to treatment. So, I mean, they're set up as clinical studies that can do that kind of analysis. But Alicia, I'll throw to you because your hand is up.
I thought I'd throw you a bone and put my hand up. So I'm going to answer a couple of those, I think. So in terms of the side effects of new treatments, and also studying PARP inhibitors, but also new ways of using PARP inhibitors in combination treatments, different sequences of treatments, etc. These are actually things that we are already involved in just outside of the Every Woman study. So through OVCAN and the OVCAN Research Consortium, which we actually have 250 members from across Canada, medical and scientific, we are funding 4 clinical trials related to PARP and or after PARP. And we are tracking very detailed information about outcomes and survival. We also just recently submitted a kind of collaborative document, which proposes to understand PARP inhibitors in a more complex way, and find ways to understand why women become resistant, how we can treat those women, and new ways of targeting those who are not likely to respond through different precision medicine. So I think I kind of answered it. There's a lot going on in this area, but just not directly through the Every Woman study.
And I think also on that too, is we do have a session coming up at the symposium on November the 6th, where a couple of the researchers will go into a couple of their research projects. So that would be a great opportunity as well to hear more about some of those. I have a couple more questions here. Will Ovarian Cancer Canada be advocating for increase in virtual access to trials across Canada to increase access to provinces and cities that don't have the high volume of trials that larger cities do? COVID has shown us that virtual connections across provinces worked when we were forced into it. So it would be amazing if this was a new standard.
Krista, I think it was Krista who wrote that question because I saw the name come up. So I would love to talk to you more about that, because that is, I mean, I think especially if you're seeing regional variation on clinical trial access, I think too, we're seeing a lot of assumptions being made. I think that's so fascinating. The whole question of who gets offered a clinical trial and what are the assumptions being made by a clinician, assuming that someone doesn't want to travel or someone, and so I think,
which was not a barrier when we asked about it.
Yeah. So I think I'd be really interested though, Krista, because I don't know much about the virtual access to clinical trials. So I think that would be a great thing to learn more about. And if COVID's opened that up, all the better. But
so another question here, this is from Pauline. For those of us over 55 years of age who had family doctors following them from their childbearing years, commonly now find ourselves without a family doctor when the physician retires. This is the question I hear a lot too. Like myself, many of my peers then went years without a family doctor before being assigned a newly minted family doctor. Would the study consider studying the relationship between doctor and patient, including GP's age, gender, years in practice, length of relationship with the patient?
That would be a great aspect to add to our next round, because that's not something we were able to tease out unless someone commented on it specifically in an open-ended question. But I think that would be a great thing to study, because it may predict urgency if there is a strong connection.
Yeah, I'm
Cailey,
curious.
do you want to?
Well, no, I mean, it's, and as somebody who lives in a rural area now, and moved from downtown Toronto to a rural area and is desperately trying to find a family physician, I hear that. I understand that, I think on a level I hadn't before, but not that it's restricted to rural areas, but the age issue, all of those aspects, I mean, it's fascinating. I could think that's it's a fascinating thing. Now with the Every Woman study format, I mean, I think that's, again, it would be tricky to kind of drill down on age and things like that of your physician. And, I mean, but I mean, that's fascinating to look at. And I wonder too, there could be other studies on the family physician, just on that issue more generally as well. So these are great suggestions and great, why it's so great to present this to people and hear their questions and the things that pop up for you too. So thank you for that.
Another question, is there any advancement in screening for ovarian cancer like we get for mammogram and pap tests?
Well, yeah, I mean, sadly, no is the short answer. I mean, there was a huge study out of the UK. I mean, everybody had really fingers crossed to see, it was like a 21-year study on various screening approaches. I think it was, you could either have a CA-125 and a transvaginal ultrasound every year, or people just had the CA-125 blood test every year, or others had the transvaginal ultrasound every year. And unfortunately, after a lengthy study, those were not deemed effective. There are obviously a lot of research projects who are looking at this. I mean, this is, the ultimate,
Holy
we would
Grail.
love the Holy Grail.
Yeah.
We would love a screening test. And I know that our governing council, our researchers we work with, ourselves, we are just waiting to look at all the, any published results on screening opportunities for early detection. But sadly, no, the research hasn't been bearing that out, that it's working.
I have one more comment here, and Alicia, I'm going to probably get your information here. So we need patient representation from our northernmost provinces, as well as Prince Edward Island, Newfoundland, and New Brunswick. So if you're okay, should I pop your email if anybody's interested in the
Yes,
chat?
please.
We'll pop Alicia's information in the chat if anybody from those areas is interested.
Well, and also just to build on that, the actual Every Woman study, we did not get anyone from the northernmost territory. So I feel like having a champion there would actually help us, get some information from women, individuals with ovarian cancer living in those areas. So yes, please hit me up if you are interested in from those areas.
So I have another question here. We still have some time. So if you're okay, we'll take the last couple questions here. Will the full report on results be shared at some point?
Yes, 100%. So we are putting together the full report, submitting it for publication, but we will make that readily available to everyone because we want everyone to see the results so we can continue to build on them.
Perfect. Now those are all of the questions that I have. If anybody else had a last minute question that they wanted to pop into the Q&A or into the chat box, like I said, we do have a couple more minutes. It's just so interesting to hear the results and how they vary. And it's nice to hear the comments from people living in those regions as well. Okay, well, if we don't have any more questions, then I want to thank both of you, Cailey and Alicia, for sharing your time, your experience, and your expertise with us tonight. We'll look forward from hearing more about this later on as well. Thanks also to everybody who joined us from across the country tonight.